I'm Carolyn Minnerly, Director of MDA Summer Camp and Support Services. We are so happy to have you join us here tonight and here in Chicago and those joining us from across the country via the live stream video. The last 2 days of the conference have been very informative and very inspiring with presentations from the MDA clinic directors and clinic team members. MDA is very fortunate to partner with brilliant doctors, and we are so compassionate and dedicated. And we have two of those physicians here with us tonight. For those of you joining us online, if you have questions as you hear information tonight, please email us at mdacconference@mdausa.org. And we'll get to as many of those as we can during our question and answers tonight. The conference today, the last couple of days, would not have been possible without the help of our co-chairs, Dr. Ericka Simpson from Houston Methodist Neurological Institute and Dr. John Day from Stanford University School of Medicine. Please help me welcome Dr. Day and Dr. Simpson.
Good evening. Thank you for the opportunity to meet with our families and our patients. My specialty is primarily adult neuromuscular medicine. I take care of adult patients with muscular dystrophies and patients in transition, and ALS patients and myasthenia gravis. And so I'm inspired daily by my patients. This meeting, I've attended previous meetings in the past as a co-chair. I've had the privilege of working behind the scenes, and we've done some novel things this year that I think have made this conference very special and unique. And I wanted to talk about that first because I think it's important to understand why we made those changes. In the past, most of our medical conferences are we sit and listen, and maybe there's time for questions. So what we did differently is we incorporated ample time for questions. We had panels of experts from a wide variety of specialties or aspects of a specific disease, answering questions of our colleagues. We also had separate sessions in the afternoon because we do have a lot of allied health, that's non-MD care providers, social workers, physical therapists, speech therapists, and so we had sessions that would appeal to them. That's important because not only is it critical for us to know what's new in terms of treatment, the science behind it, and the potential therapies coming down the pike. But in order for us to sort of provide care to our patients across this region and this nation, all physicians have to know, and we have to exchange information, and we have to teach each other. The third thing that was so special is we did have panel discussions today in particular that dealt with ethics in genetic testing, but also dealt with palliative care and hospice care. Those are two words that we as physicians and often patients don't like to discuss, but it was very enlightening, and there were family members of patients there talking, and I think it gave myself as a clinician a greater perspective of what our patients go through. And I told this mother that it's going to make me a better physician. So there are questions about what's new in treatment, what drug is coming down the pike, but it's also important to know that just the care, the day-to-day way that we manage our patients is just as important, and I think this conference has really addressed that. So I hope you're pleased. I'm telling you, you should be pleased because the outcome has been very good so far. So I actually made a number of notes. I do have some slides that don't begin to cover, and this is primarily the first day, which was yesterday. We did have, for the first time, a keynote address by Dr. Thornton, who's from Rochester. He really is leading the way in terms of research in myotonic dystrophies based on what we know about the gene mutation and potential therapies, and he really set the stage for how we should think about research in our diseases, care for our diseases, and how we need to prepare for what's coming. And so I'll start there. Across all diseases, most of them underneath MDA, and that includes the dystrophinopathies, Duchenne and Becker's, that includes other limb girdle dystrophies, spinal muscular atrophy, and even ALS, diseases that either we don't know what's causing it or we know that it's a gene mutation, but whenever you hear about inheritance, you hear there's no treatment. Well, we can no longer say that potentially because of very sophisticated gene therapy, potentially we have the ability in the next decade to alter the course of inherited diseases. And so Dr. Thornton talked to us about advanced planning with an expectant hope that we as clinics and physicians need to work together to determine what's the best way to measure benefit, what's the best way to exchange information, and what's the best way to structure our clinics so that we're all on the same page when these things come down the pike, as they will. One of the other sessions dealt on neuroimaging or muscle MRI. Typically in my hands, MRI is for the brain or the spinal cord. But as a neuromuscular person, I know that its use looking at muscle and nerve is very important. And so Dr. Mancotti gave an excellent talk on the clinical use of MRI in muscle diseases. Number one, it has the potential as a research tool because there's evidence that it shows changes in the muscle as the disease progresses. If you look to the left, it's a little dark, but this is a slice. If you were to cut the thigh as if it's a nice steak or something like that, or a flank, on the left is the fat around it, and the dark area is basically normal looking muscle. And however, if you look on the right, that's an MRI of a young boy with Duchenne, and you see some early changes in the muscle. It's not as dark. There's some lighter areas that suggest fatty replacement. And so she showed some evidence that that could be monitored without being invasive, without biopsies, and used as a research tool, but also as a tool to monitor patients. One of the other talks, which was very good, was on neurorehabilitation. And actually a lot of data was presented in most of the muscular dystrophies, Duchenne, limb girdles, myotonic dystrophy. But what it showed is that exercise is good, if I had to sort of summarize it. I think, in the past, there's been a hesitation to support exercise. There's a fear that you'll wear out the muscle. But now the data is suggesting that it actually, with a formal, tailored, monitored program, benefits our patients from Duchenne muscular dystrophy, even young boys with this disease who are wheelchair bound already. That assisted exercise, assisted bicycling, improves endurance and function, although they remained in the wheelchair for those that were. And this is one such study looking at patients who had motor ability after 24 weeks. The group that received an exercise program for 24 weeks without any interruption did better, although the ability to walk didn't change. But this is one of the earlier studies that suggested that there was benefit as well. And so there was more data presented on other dystrophies, including myotonic dystrophy, that showed great improvement as well. So I think that changes the way we think about these diseases, that exercise does have a place. It is important. If you don't use it, you'll lose it. And so I think that's important for us as clinicians and for our families. It just needs to be under a program that is specific, that is prescribed by someone who has experience with our patients, with you, and that someone who can monitor the progress. One of the interesting talks, and maybe Dr. Day can talk more about it, is the use of robotic devices in neuromuscular disease, and one in particular is JACO. These are robotic devices, robotic arms, which make it easier for our patients who have limited upper extremity mobility and strength to do things independently. And he provided some wonderful movies and pictures that were astounding in terms of what it allowed our patients to do. I've been keeping a list of everything JACO has allowed me to do on my own, and here you have it. And this is just one slide out of 3. So this was very exciting. Raise my hand in school, turn on the computer, open cupboards, drink with straw, and carry cup around, open the door. So that was very exciting as well. So not only is it just drugs, but it's exercise and it's equipment and things that make a difference in terms of one's ability to do. I am an ALS specialist. It's very dear to my heart. And as a member of a multidisciplinary team, I know that that has one of the biggest impacts on how our patients do. And that's not limited to ALS. It's equally important for all other diseases that require multiple allied health professionals, persons that deal with not only the neurologic issue, but safe mobility, respiration, cardiology, genetics. And so in ALS, this actually has been associated with improved survival in our patients. We only have one FDA-approved drug for ALS, but this is what's made the difference, in addition to being very aggressive with one's breathing, initiating BiPAP or CPAPs, cough assist devices, vibratory vests, things that are used not only by our ALS patients, but many patients with other diseases, from the dystrophies to SMA as well. It makes a difference, and it's very important for early initiation and monitoring. One of the favorite parts in What's New was a hands-on pulmonary session. When attendees registered for our conference, they had the opportunity to sign up for sessions where they could rotate among 5 rooms and actually have a demonstration and play with the machines that many of our patients have to deal with every day of their life. And so as a physician, it's one thing to prescribe it or to write an order. It's another thing to actually put your hands on it, manage it, try it out, and to see exactly what our patients have to wear and deal with and change out, and care providers as well. So these are just a few pictures I took yesterday. This is Dr. Vanessa Holland running a group about air stacking with an ambu bag, metineb, vibratory vest for secretion control. There was a lot of talk on ventilators, also on diaphragm pacing in our patients, specifically ALS. This is Lisa Wolf, who coordinated this whole session, talking about tracheostomies, different types of trach collars and tubes for what patient and when, having a plan for the patient and the family if there's an issue with the trach, and such. And here's a picture of one of our clinicians actually handling a trach. Not many clinicians can say they've handled a trach. Some do, but so I thought this session was extremely special and needed because it gave us hands-on experience with something. So again, it helped us. I'm going to finish with palliative care. It was a pretty significant morning. As I said, we had 2 mothers of children with type 1 SMA who gave their stories from a pre-screening genetic point of view and also from a palliative view, and what was done well and what could have been improved. And so I'll tell you that for a lot of clinicians, we were more quiet than normal because it really impacted us to hear that. And you would think that we hear every day, but not. Most of our patients don't have 30 minutes to 40 minutes just to talk. And so these 2 mothers had a captive audience, and it was wonderful. One of the things that I learned, and I knew this from my ALS, but she made it very clear, and this is that palliative care does not equal hospice care. And a lot of people get that confused. Palliative care is for anyone with a serious disease that has a lot of burden to it. A lot is required. It does not equate to end of life, 6 months to live. So this can be started at the time of diagnosis. Any age, any stage, and it can be provided along with disease treatment, whether it's rehab, whether it's clinical trials, whether it's steroids for Duchenne, it goes along with it, whereas hospice is home-based palliative care for patients who are expected to live less than 6 months, but not necessarily. So there are patients on home hospice for up to a year. The one thing that she informed us is that with the Healthcare Reform Act of 2010, that children enrolled in any palliative care program can, in addition, receive curative and directed care at the same time. Because in the past, once you went to palliative care, any treatment that you underwent from your doctor had to stop. And so now children under the age of 21 can receive both without any restriction, and that's extremely important. And it's important, we're not quite there for our adult patients, except for our veterans. And so it's been referred as open access, concurrent care, and I thought that was wonderful. And she made some comments that stuck out to me. Maybe you already know this, but many physicians are afraid to have these conversations or don't know when to have these conversations. The data she presented reflected that most of us think we should have these conversations at the beginning, but when you look at what we're doing, we're not having these conversations. And she made us aware that many patients and families want the conversations. And so the study that she presented suggested that by engaging in these discussions, it doesn't cause the patient to feel worse psychologically or physically. It does not diminish hope or affect or increase psychological stress. And under calm, non-acute, non-emergent circumstances, it's a healthy and it's the right thing to do. So I'm going to stop there, and I'm going to let Dr. Day give his highlights, and then we're open to questions. Thank you. Yes.
Thanks, Ericka. So it's been great working with Ericka on this and working with the MDA team. I'm John Day. I'm currently from Stanford. I was at the University of Minnesota and Gillette Hospital for about 20 years, so knew a number of MDA clients and professionals there. But now am at Stanford and actually see patients at both the pediatric and the adult hospital, so that we're working very hard to integrate care across the lifetime there so that we can take care of young kids and keep taking care of them as they become adults, as well as taking care of their parents or other adults that are affected by adult onset forms of these disorders. So we're very interested to participate in this conference in large part because it brings together all of the different providers that are so integral to the MDA clinics and MDA activity overall, so that the occupational and physical therapists, respiratory therapists, speech therapists, as well as the physiatrists and pulmonologists and cardiologists and everybody else that really allows us to provide the comprehensive care that patients need. So I think it's been an incredible couple of days that we've had, as Ericka has already discussed. And we have one more day coming that's going to allow us to get into the cutting edge scientific side of this. Where are we heading in terms of various types of hopefully meaningful treatments? But the day today was just as jam-packed as the one that Ericka described for the first day. And much of today was focused on standards of care. How are we going to make sure that we're providing adequate care and sufficient care for patients, and then dealing with that and discussing that in a number of different ways. So we have concurrent sessions going on, so no one can go to all the meetings, and as a consequence, Ericka and I have been kind of divvying this up and going to different sessions. We started out this morning hearing from Julie Bolin from the Centers of Disease Control, and a lot of people are somewhat surprised to find out that neuromuscular diseases are really very high on the list of things that the CDC is now interested in, because we're trying to understand the demographics and epidemiology of these diseases, as well as understanding appropriate ways of caring for patients to assure that we're providing optimal care. And so she discussed that, talked about the care considerations specifically for Duchenne and Becker muscular dystrophy that were actually released first in 2000, and included within that the family-friendly version that families can access so that they can assure that we're doing everything that we need to help boys affected by this very common form of muscular dystrophy. Those are now being expanded and revised and revisited to make sure that we're completely up to date. And so that's work that Julie at the CDC has been very importantly directing. The CDC has been working with the American Academy of Neurology to develop care considerations, they're called. The terminology here gets a little bit opaque, but basically these are coming up with the best evidence that we have for how to deal with certain aspects of these different diseases. The one underlying message is we have a lot of research yet to do to really define the best care, and so that hopefully we'll be able to develop more specific care guidelines in the future. But the care considerations that we're now being able to pull together for limb girdle muscular dystrophy, facioscapulohumeral dystrophy, myotonic dystrophy, and the congenital muscular dystrophies are all in process and should be published later on this year in the beginning of 2015 by the American Academy of Neurology, and then the MDA is going to work to make sure that those are distributed and publicized to further increase our efforts to maintain control of patient care. Setting guidelines, having standards of care is a very, very important aspect to all aspects of what we're doing with the Muscular Dystrophy Association. If we want to do good research, we really have to start from a common baseline. We have to have all of the patients treated the same way before we can tell whether or not new treatments are really effective or not. And speaking of new treatments, we actually had a very important conversation this morning organized by Tim Miller and Abby Bronson, talking about access to experimental therapeutics. This is a very, very pressing issue, and I think a lot of us are excited and cautiously optimistic that we're on the verge of coming up with some of the gene modification treatments that Ericka was mentioning, and that this has the potential to really shift the game plan in terms of dealing with neuromuscular diseases. And we don't want to overhype this. We have to do this in a very sensible, rational way to prove that these things work. But we also want to make sure that we have the ability to immediately get any new treatments to the people that need them as quickly as possible. And so that is an issue that needs to be addressed up front. We can't just wait until we have a drug and then hope that we can distribute it widely. So this was a very, very important session that Tim and Abby organized, and we're working together to make sure that we maintain the patient population as being foremost in the eyes of the regulators and the pharmaceutical companies, as well as all physicians, to make sure that we are focusing on patients and helping get these medications as soon as they're proven to be effective. It's not a simple solution. These drugs, if the gene modification treatments prove to be effective, are not going to be cheap. And so it's a matter of finding ways that they're going to be paid for as well as distributed. And there are a number of questions involved that were discussed at this session. So no answers yet, but the MDA is working very closely with the FDA and with the drug companies, as well as obviously with the patient population, to make sure that everything that we can do is moving this forward. I think there's some later questions that will come to additional aspects of that. Much of the morning then was spent, as Ericka pointed out, with the two families, two mothers with spinal muscular atrophy that had affected their children, both of whom succumbed to the disease in their first year of life. And one aspect was with regard to the palliative care and end-of-life issues that Ericka described, and another aspect was surrounding genetic testing. And so we had a very, very poignant discussion about the ethics as well as the practical features of genetic testing. As many of you are fully aware, genetic testing abilities has gotten dramatically more capable, and so we are able to do testing for any number of different diseases. But the question is, when do you do it? How do you do it? On whom do you do it? And again, the overriding message was that the patient has to be absolutely at the center of that discussion, so that all too often we hear stories of physicians who send off genetic test results, and patients are surprised to find out what runs in their family and the implications of that. It's also becoming increasingly possible to do this on your own. You can almost, 23andMe has been kind of slowed down at the moment, but you could do this on your own and sometimes find disease-associated genetic changes. And what do you do with that information? It can be really quite troubling or even devastating to get information that you don't fully understand or don't know the implications of. And so there was a very important discussion about how we should best approach that and help patients in dealing with that information. So that really dealt with much of the morning. The afternoon was divided into two different sessions, one that Ericka chaired that dealt with different specific disorders. Karsten Bonneman talked about congenital muscle disease and a number of things that are going on in that sphere of the MDA, and gave this list of various trials that are underway with regard to specific forms of congenital muscle disease. So that there are several trials, both for natural history studies and increasingly for various therapies, such as the hyperinsufflation trial that's just started in Cincinnati for collagen 6 forms of congenital muscular dystrophy, and the antioxidant trial for the ryanodine receptor, or form of congenital muscle disease that the NIH hopes to launch very soon, as well as the myotubular myopathy that has a couple of forms of treatment in the pipeline. We had a number of interesting discussions about myasthenia gravis, both on the adult side as well as on the pediatric side, with Gil Wolfe from Buffalo talking about the current state of affairs with regard to adult onset myasthenia gravis, focusing on new antibody approaches that might be able to be more effective for those patients who have not responded to current forms of treatment, as well as talking about the role of thymectomy. So that this is an ongoing question mark, but there's increasing evidence now. We've always recommended it in a subset of patients, but now we're actually getting more evidence to support and help us decide in which patients thymectomy is going to be useful. So we're very optimistic about that and hope that it leads to a different form of more rational decision-making for treatment of myasthenia in the near future. This was also echoed by Susan Iannacone from the University of Texas in Dallas, who talked about similar issues with thymectomy in children. And basically, to just skip over this relatively quickly, in this retrospective study, she was able to look and see that for patients that had pre-thymectomy, so A is bad and A is good and E is bad, so that there was a tendency for the younger children in this study to be affected in this B and C level pre-thymectomy, as opposed to the older children that had a fairly distributed range, but more of them were in the C and D levels of disease severity. Post-thymectomy, then, we can see that these children tended then to be in the A and B level for both older prepubertal, postpubertal, and younger prepubertal patients. So early data, not confirmatory, but suggesting that thymectomy helps by shifting these more severely affected C and D level patients to the less severely affected A and B level patients. But in essence, what this shows that in children, like in adults, it's going to be helpful to do what's called a prospective study, where we can actually watch these patients over time to see how they're doing. Mike Schei talked about his really groundbreaking work in Charcot-Marie Tooth inherited neuropathies, where he has helped establish this 17-site clinical research network that has been collecting a lot of information about various forms of CMT, with approximately 5,000 patients almost now enrolled in that study, and a number of results coming to the fore. So that there's an awful lot of work that's being done. New forms, new genetic causes are being identified, and the natural history of the disease is being established. That might sound boring. Natural history has this kind of boring sound to it, but unless we really know how a disease is going to progress, we can't really tell that we're doing anything beneficial by giving you a new drug. If we give you a new drug and you just feel a whole lot better, you might feel like you're doing better on that drug, but we have to prove it more rigorously than that. And in order to do that, we have to know what that baseline is. And so it's very, very critical foundational work to get this natural history piece so that as we launch into these drug trials, we can do them much more meaningfully and get some results that tell us what to do. That's it for the slides I have, because I wasn't able to put the last session in slides. Just an hour ago, if you were in this room, it was set up very differently. The staff has been working hard to change the tables around, but we had about 100 or more people in here involved in a very, very active session discussing what was called specialized care for neuromuscular patients. There was a session on specifically aspects of women's health, a very, very lively discussion on sexuality in neuromuscular patients, helping neuromuscular patients figure out how to develop more romantic relationships, what are the barriers that they have, and how can the MDA and our MDA clinics help in overcoming those barriers. It was very, very useful. And then we talked about the importance of addressing emotional health, both depression specifically in one study and then just emotional health more generally, and the fact that all too often those issues can kind of fall to the side if we're focusing too much on wheelchairs and breathing and BiPAP machines and nutrition. And so I think that was a very, very important session and was very well received, and many people, I think, are changing their whole approach to practice. Another aspect of care that's very dear to my heart that we then discussed was transitional care, meaning that we have to do a better job of helping patients as they become adults with childhood onset disease. Thank goodness we do have a much better ability to care for patients today, even if we haven't got the definitive treatments yet. And so we no longer expect Duchenne patients to not have to deal with college applications. We expect that to be a part of the life of boys affected with Duchenne. And so we have to be thinking about how do we help them transition to a more independent adult lifestyle as we're able to help them get older and remain more healthy and active. So that I think that's true across the board with other forms of neuromuscular disease as well. And it's a very, very exciting time. It lays the groundwork. Now all we need are those definitive treatments to kind of push us across the goal line. But I think it's a very exciting time, and it was a very exciting meeting. Then we had another important talk about the special needs, if you will, of children in families that have a disabled sibling, but what about the needs of the children that themselves aren't disabled? And I think that is another important aspect of care that we have all too often not paid enough attention to. The siblings of affected neuromuscular patients are natural allies. They're the people in the world who know these diseases intimately, but can get burned out themselves at a very early age if we don't help them learn how to work with these disorders, both in the family and then as they grow up. They bring incredible insight and ability with them, And so it's a very exciting opportunity to work with that population to make sure that we're doing everything that we all can to help their affected sibs. So it was a great meeting so far. We've got another day upcoming, and I think I'm gonna stop blathering at this point, and we'll open up the mics for questions. So you want us to start answering the questions that you provided, or Jody, do you want us to just take a couple of these?
Yeah, they came in ahead of time.
Okay. Do you want to try one, or do you want to?
Let me explain what you're reading. So to the people in the room, and if you're feeling shy and then you get up the nerve to ask a question, come up. But we have people watching the live stream who've been sending us questions. So we've had a lot of questions coming in while this has been going on. A few came in early, so we'll start with those, and then we'll keep reading questions from the live stream. But if that spurs something, come up and ask your question in the room by all means.
So one question was from Marlene. My son is 16 years old and has Duchenne muscular dystrophy. Based on current information, would declining respiratory functions, spinal health, cardiac functions benefit from being put back on a corticosteroid regimen? And actually this was brought up at yesterday afternoon's conference dealing with cardiology, cardiac monitoring, and management and pulmonary management in patients. And the question was posed, and actually, just based on the discussion, although there's not a significant amount of data, it would appear that the practice guideline, or at least in the field, and Dr. Day can speak more on that, is to continue steroids unless there are significant side effects or complications. There's no evidence-based guideline or indication to prove that, but there was some discussion that there may be benefit even to the cardiac function of patients who remain on steroids for an extended length of time. There was also a discussion as to if someone who was never treated with steroids, is there any benefit to starting them later in life, such as in the late teens or early 20s? And there wasn't not 10,000 hands didn't rise up, but there were a couple of specialists who stated that they would at least begin a trial of steroids if they were tolerated, to see if it did improve any type of function, cardiac or otherwise. Dr. Day, did you want to speak to that at all?
Yeah, I think you summarized it really accurately. The evidence is increasingly present that that it's helpful in terms of muscle function to stay on steroids even after boys become non-ambulatory. That the steroids can help in terms of strength of breathing and strength of upper extremity function. So there's increasing evidence to support that. The downside of steroids is, of course, all the other factors, the effects on bones, the effects on body weight, and so to the extent that those are more affected the longer you stay on them, people have been concerned about that. And so I think that the consensus, and again, this is just a bunch of guys sitting around and kind of raising their hands, as to what they like to do. As Ericka pointed out, there's no strong data to support it, but the consensus is that staying on the drugs definitely is good. Whether or not to start the drugs is the question. And so I think it comes down to individual circumstances. And each patient is different with regard to those side effects I was mentioning, as well as to the potential benefits. And so I think you have to work this out on an individual basis, but that's kind of the current state of understanding.
I had a question relating to the treatments that are being developed currently. There's several clinical trials and things going on. A lot of them right now, because of the need to be very scientifically focused, are focused on young children with the conditions. And my question is, what are the thoughts about how these treatments will impact older children and adults with the same conditions, and whether there will be other trials to test it for adults, or what your thoughts are on that?
Want me to take that?
Yes.
So, no, that's a great question, and we've had similar discussions. So, we've worked to develop some outcome measures. So, an outcome measure is something that you can follow after you start a new drug. We have to prove to the Food and Drug Administration that a drug is effective, that it actually makes someone's life better, and so we have to have a way of measuring that. And so the first order of business before we can do a trial in, for instance, non-ambulatory patients, is to develop a measure to show whether or not it's beneficial. And there's been effort on that, and I think we have some good measures now for upper extremity function. We also have some good measures for breathing function that allow us to do those studies. So I think that those will get launched. In spinal muscular atrophy, we are doing a study now for infants. You're right, it gives us a way of studying the effect of one of these new drugs in a way that we think will be clear to the FDA. But we're also starting a trial of older children who are non-ambulatory so that we can see the effects in them. It's not clear what's going to happen if these drugs are approved. If a drug is approved for infants with SMA, what do we have to prove to get it also available for non-ambulatory older children or adults with SMA? And it becomes a matter of the FDA regulations, but it also more practically becomes a matter of who's going to pay for it. Because again, we'll come back to the fact that these have the potential to be very expensive drugs. So it is very, very much in our focus to start doing these trials in older individuals who are affected, in whom we still hope that the drug is going to help at least stabilize their course, but ideally to improve their function. So a lot of blah, 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 but that's kind of the shtick. All right, should we take another one? See if we can get you guys heated up here. Maybe we have to say something controversial so we get everybody jumping up and down.
What is the general prognosis in adults with CMT2C? In your experience, how likely are they to become ventilator dependent? And this is from Charles.
Yeah, that's kind of a stump the stars kind of a question, I think. It's, so I don't know where Mike Shy is, but we can try to get him in here. CM2 type 2C is one of the less common forms of CMT. And it's, I'll show you everything I know about 2C here in about 5 words. But it's a little more variable in its presentation, as they say, so that it can present in children. So you can have children that are affected by the neuropathy, but it might not be obvious until adulthood. And so it really runs the range, and it makes it very hard to give a blanket answer to that. I think that in all likelihood, compared to certainly other forms of neuromuscular disease, the likelihood of needing ventilatory support is not high. And in compared to certain other types of CMT type 2, I would say it's also less likely. But beyond that, I'm not going to dare tread.
I'll add a little bit. I agree with Dr. Day. For most CMTs, we don't have to necessarily deal with a lot of pulmonary distress. For this particular kind, it is rare. How it presents in a family does vary, from mild to minimal symptoms. And I think maybe this patient or father is addressing what has been reported occasionally with this type, which is vocal cord paralysis or even diaphragm weakness. in certain family members with this particular mutation. Not common when you think about Charcot-Marie-Tooth, but it has been reported with this. And so I think no different than with any of our patients who have any type of respiratory weakness or airway ability to handle their secretions or speak, that they would need intervention like anyone else, whether that's cough assist or ventilatory support, feeding tubes, or any type of enhanced nutrition. So it depends on the patient. It always depends on the patient.
So did we provoke? Oh, good.
Yeah, I wanted to ask, looking through some of the different topics that have been discussed over the last couple days, I'm excited as both a patient and family member with neuromuscular disease that some physicians are being introduced to such a wide variety of topics that many of us think about and deal with on a regular basis. However, I'm wondering if there's any way that we as patients and family members can look at some of the discussion or look at some of the presentation materials on our own so we can become more educated as well.
I think that's a great question, and I would have to defer to somebody from the MDA as in terms of what the plans are with anything you're collecting. I don't know what kind of summary you're anticipating.
Yes, we'll be publishing some summaries in our Quest News online articles. And then we can also, in many cases, reference some journal articles that you may be able to reference to get some of the background information on that. But we will have a 3-part series after this conference to give more detail about what was discussed and referencing some of those details.
And this forum, which I believe is the first of its kind at a meeting, is the first step to providing, real-time information to patients and families about what we're learning and the information we're exchanging. I also would encourage you as a patient or family member to take whatever you've read, and many of you do, obviously, and go back to your care providers. Mine come to me all the time with articles and things from Quest, and they want more detail. And sometimes I have to go back to my resources and sort of look a little further, but that's good. And so I know you all do. I would just encourage you to continue to do that. Not that you can't go through all of this data. Sometimes even we have to sort of look very close at what's presented to us because it is so technical and scientific. But you do need your trusted physician, your trusted care provider to go over it with you. I would encourage that.
And one other point for everybody in this room and all of our online viewers, that we have bloggers here at the conference, and you can see those blogs. One is written from one of MDA's science writers, and 2 from individuals served by MDA who are here and blogging their perspectives and what they've learned and the information they've gleaned. And I think that can really be helpful to everybody. And you can access those via MDA's Facebook page, and you can also access those via mda.org. Once this session is over.
I mean, I would just also make the point that, while the MDA clinic providers, certainly have a lot of expertise in a lot of different ways, I mean, there's full awareness that, the families and the patients have expertise that we need to learn from. And so I think that, this has to be a dialogue, and, we participate all of us in various MDA forums, back at the regional and state and local levels, as well as at the national level, in order to facilitate that back and forth communication, because we're learning all the time. You teach us a ton about, what really is important as well as what's really going on. So I really appreciate that.
I have 2 different questions. The first one is there any looking in the transition for older kids with Duchenne that have cognitive issues also, that college is not a possibility? And then my second question is there any discussion on pain? Is there any protocol for someone with Duchenne that has pain, because I have a son, 29, with Duchenne, and we just keep getting many different drugs. So I just wonder if there's some protocol.
Excellent question. So that with regard to transitional care, there is a very great awareness of the need for helping individuals who have cognitive involvement or behavioral involvement, as well as motor disabilities. that cuts across other diseases, so that another very common form of muscle disease is myotonic dystrophy. Myotonic dystrophy very commonly has cognitive and behavioral issues associated with it. And so there's another instance where the MDA helping to bring us together, where we're not just focused on one disease, gives us enough understanding and impact and experience that we can really address these things. And so, yes, that's very much a key element, and came up in a conference that I was at a few weeks ago on, how are we going to help transition people who have a combination of behavioral and motor difficulties, and I think that's a really key one. Your second question, pain. Yes, and we had a great discussion on pain that Dr. Greg Carter did from the University of Washington, and there's no simple answer. So that's the first order of business, is that there's no magic bullet that just eliminates pain. Almost, how do I put this and not put my foot in my mouth? But at any rate, many neuromuscular diseases are, if you read in the textbook, it says nothing about pain. ALS doesn't cause pain. Duchenne doesn't cause pain. It's a bunch of hokum. I mean, a lot of patients with these disorders do have pain that oftentimes is secondary. So that one of the things that can be secondary to is just immobility. That as you stop moving, you get tighter, you get more pressure on the same spot all the time. And so one of the key elements that Dr. Carter talked about was the importance of various kinds of exercise. And what does that mean? Well, it can mean stretching exercise. One of the ones that he and and I'm sure Ericka promote is water therapy. I mean, water therapy has been an absolute godsend to any number of our patients, because they get into a warm therapeutic pool, so it has to be in the mid-90s usually. It's warm, because if you get in one of these cold, athletic pools at the YMCA, you're just going to tie up in knots and you're going to have more pain. But if you get into one of these warm pools and you do it on a regular basis, and I usually encourage patients, the hassle factor of getting into water is huge, okay? So you have to get there, you have to change clothes, you have to get in the water, you have to get out of the water, all this stuff. And so it's a major hassle. And so, it's hard to kind of sign on in a large way. But if you can just say, okay, I'm going to try this 3 times or 4 times, once every other week, it oftentimes gives you enough experience where you begin to see that it actually does have benefit, because it helps you start moving muscles and joints that you haven't moved in a long time. And that can reduce the pain. And after that, there are other things. There are types of physical therapy, massage therapy, non-narcotic forms of treatment. And then we get into the pharmacology, as you say, that oftentimes people expect too much of. It's rarely going to eliminate the pain, but it can knock it down a few notches, especially if you're doing it in concert with the physical therapy and other types of movement.
Is it safe to assume that all the pain is from the disease, rather than could it be some other issue? Should that be investigated, or should
it depend? Yeah, excellent question. I mean, and you definitely need to figure out where the pain is. And this is hopefully where some of the neuromuscular specialists that you're working with will know if this seems to be consistent with the type of pain we see in that disorder or not. You can get compressed nerves, you can get slipped discs, you can get pain from pressure sores, you can get all kinds of things. Wheelchairs have, increasingly, we don't have to fight really to get a tilt in space on a wheelchair anymore, to get recline on a wheelchair anymore. You used to have to fight like the Dickens to get that, because they didn't think, the insurance companies didn't agree that it was beneficial. Now they allow us to do that, but all too often I find that patients aren't using it. That we get that tilt put on the chair, And we want you to use it, several times a day. I usually ask my patients to try to tilt at least twice, if not 3 times a day for a half hour at a time. And it's ballpark, there's very little science behind it, but it helps to shift things around to eliminate some pain. But by all means, you have to eliminate other causes. I'm sorry, Ericka, you had some other
I
ideas.
just wanted to comment about pain above and beyond just the obvious causes that we really don't know. It's very possible certain disorders have more pain than others, and I'm not sure it can be explained by just contractures or muscle wasting. FSHD, often facioscapulomuscular dystrophy. These patients' pain is a significant complaint. Even in our ALS community, depending on the type, whether it's more spastic or not. But some of these, there may be a more centralized pain above and beyond that's hard to prove. I just wanted to reiterate what Dr. Day said about being proactive, and what would be optimal would be preventative. That early on, you begin stretching and water therapy. If the patient can't do active stretching, passive stretching by family member or caregiver, so important to prevent frozen shoulders and contractures at the knees and the elbows. It makes such a difference long term. And so in a proactive, preventative way, it's extremely important. However, we do see patients, but that by the time they see us, it's a little too late. There are painful contractures and skin breakdown and bony surfaces on the bottom. And medications are not the magic bullet by any stretch of the imagination. So it does require working with DMEs and changing the seat and the bed and the chair and the tilt. I've also worked with physiatrists who just sort of know how to prescribe the right cushion, and even certain pain doctors who are not necessarily pill pushers, who have, in a couple of my advanced Duchenne patients, have done nerve blocks safely for intractable pain. So I just think you have to be creative. It has to be tailored for the patient, and you need to work with your physician and who they trust.
Katrina.
Yeah, I have a question following up on that issue. Once a person has contractures, how do we treat them? And we've heard about Botox possibly being a treatment. Does that really work?
No. I mean, in short, Botox is really, that's probably a little oversimple, but Botox is really useful for spasticity, so that, which is the increase in muscle tension caused by central nervous system problems. Okay, so that children with cerebral palsy, for instance, have problems with spasticity, and that responds to Botox, because what Botox does is it basically blocks the signal of nerve to muscle. The problem in muscular dystrophy contractures is largely one of fibrosis, where you're getting scar tissue forming that's restricting the movement of the joint. And that making the muscle weaker is not going to help. The other problem with Botox is that it makes the muscle weaker. So if you're already starting out with weak muscles, you have to be really quite cautious in your use of something like Botox, especially for disorders like spinal muscular atrophy, where there's already an impaired communication between nerve and muscle. If we give anything that further complicates that, we could get into difficulty.
So of course, there is device manipulation, dynamic splints, things that progressively, if the contracture can be reversed to whatever degree, there are surgical things that really haven't been well studied, but sometimes just for pain management and the ability to transfer help. But I agree, Botox for those have no indication.
One more question. Do studies or practical experience show that women with SMA will experience disease progression during pregnancy?
That came up in our discussion about women's health earlier today. There were questions, and there is at least some anecdotal information to say that some women do get weaker, but I think it's a little too sketchy to know for sure. Certainly carrying the weight of a pregnancy is going to slow any woman down. And then you have the issue of regaining the strength that has been lost. And that's a problem for our patients with neuromuscular disorders. That whole kind of rehabilitation can be really quite protracted. And so, there are multiple elements to that question. It may have a direct effect. It undoubtedly has a kind of functional effect where you're having to carry extra weight, so you're going to have more weakness during it. And then you also have this difficulty in terms of rehabilitation from that deficit. So I think that's about all I can add to that.
We have a question that came in online, and this family would like to know if antisense was discussed for myotonic dystrophy during the conference, and what the update is on that.
So Dr. Thornton did talk about antisense to some extent. His talk was really more looking forward and what do we need to be thinking about if the antisense works. So we have talked a lot about antisense, and I think there is information that is public about the plans for this antisense trial to launch this year with phase 1 studies. So phase 1 studies are done, they don't even have to be in myotonic dystrophy patients, they can be in controlled patients, just to see whether or not the drug causes any unexpected toxicity. And so that will be done this year, and then we hope that soon thereafter that we would be able to start a phase 2 trial, which again would be probably small numbers of patients, on the order of probably 15 to 25, I would guess. This is just pulling numbers out of the air. There's no protocol written, there's no data on that yet. I can't give you any specifics on it yet. But that's kind of the current thought. So we are optimistic about it. It works well in animals, and we hope we're in clinical trials this year. Was there another question out there? Should I take some of these? Oh,
I was just curious.
We need you to use a mic. Hang on just a sec. Thanks.
I'm sorry. Thank you. I was just curious. You were talking about the exercise component of people with MDA, but specifically myotonic dystrophy. And we were told at one point in time to avoid exercising to the point of having a burn sensation, which was supposed to be good in exercise, but not with myotonia. Is there any research about like what's too far?
Yeah, I mean there's research as to what's too far, but it's not simple. It's not a simple answer. So that our usual rule of thumb is not necessarily that you don't develop any kind of discomfort. I mean, exercise by its very nature, is tiring, and it can certainly be uncomfortable during the exercise. The usual rule of thumb is that if 12 hours or certainly 24 hours after you exercised, that you're still feeling pain or you're still feeling like your muscles are just rubbery and super exhausted, then that was too much. And so the rule of thumb is that you set your exercise level to something that's going to be sustainable. It doesn't help to go and lift weights, for 4 hours straight once every 6 months. That's of no value. And so the point is to find a degree of exercise that you can sustain. And what Dr. McDonald was pointing out to us yesterday, that a very common cutoff mark is to not go, if you're talking about weightlifting, but you can try to extrapolate this to other forms of exercise, if you just do whatever the weight is that you can just barely do once, okay, that's your max that you can do once. Don't go over a third of that, okay, in terms of regular exercise, so that that kind of relatively light or low impact exercise is what we're striving for. So we don't really want high impact exercise. And there are other types of exercise that are better than some that are worse. The type that is worst is what's called eccentric contraction. So that's, if you're doing muscle curls, when you're pulling your arm up, the muscle is shortening while it's contracting in your biceps. But when you're letting that weight back down, the muscle is lengthening, but you're still contracting. Okay, so that's called eccentric exercise, and that's harder on muscle. That definitely tears a muscle up more. So that there are these types of exercise. So we recommend a lot of stretching, a lot of balance work, a lot of aerobics that aren't going to be as traumatic, and then some degree of strengthening exercise, but again, with those caveats and limitations.
We have 3 very similar questions that have come in from individuals with SMA that are watching right now. And one of those is, for some of the therapeutics that you're talking about, will someone that's in their 30s, 40s, 50s with SMA type 2 or 3, will some of these therapeutics help boost their strength, maintain their strength? Do we affect, or will it not influence them at all? So we've had 3 questions.
Yeah, those are such great questions, and we're not going to have great answers for them. It's the kind of thing that we can't do in animal models. We can't answer things like that very well. And so we're not going to know till we get in there. And the way we usually look at these things is that we want to provide what we can to prevent the disease from getting worse. And so to the extent that building up the amount of the SMN protein in the nerve cells helps make them healthier and prevents them from deteriorating, then it will help stabilize. Now, if you want to be optimistic about this, but again, there's no good data to tell us, what might happen is that if those nerve cells are healthier, then they're actually going to be able to more effectively innervate more muscle fibers. And so you might actually see some degree of improvement. And we should start getting some information on that, not in the 30 and 40-year-olds yet, but in the 2 to 14-year-olds that we have started, who had already kind of reached a relative plateau in terms of their muscle function. They were no longer in that downhill phase. They had relatively flattened out. And so over the next several years, we'll get more insight into that. I hope that gives them a sense of an answer to that. We had a question earlier. What is the MDA and the participating professionals, I guess what are the MDA and the participating professionals doing to influence the FDA on approving eteplirsen, along with the changing how the FDA is structuring the trial requirements and criteria? And basically, I think the MDA is doing everything it can. It's really working very hard on this. I alluded to this a little bit earlier, advocating with the FDA as well as with the drug companies. And I know that there's also a program out of the White House trying to develop kind of increasing pressure to develop an approach. I'm going to mess this up, Annie. I'm going to have to turn to Annie. She coached me. She coached me beforehand. And
okay. Just want to clarify that. So, first of all, MDA. So, as Dr. Day just said, MDA is extremely committed to all of the therapies in our pipeline and making sure that safe and effective therapies are delivered to our community. And I'm sorry, my back is to everybody. Are at the first moment possible. And so to that end, we've been working, so to the way that the question was framed, to that end, we've been working to ensure that there is a pipeline for approval with the FDA. And so if you've been following publications put out by MDA and a lot of our advocacy partners, there was a reauthorization of what's called the Food and Drug Administration Safety Innovation Act about a year and a half ago. And we worked closely with our advocacy partners to make sure that there were provisions within that made sure that the rare disease community, which is us, were well considered within those provisions. Specifically to this question, exon skipping therapies, of which eteplirsen is one, but also includes many other therapies in our pipeline, are of a priority to MDA, and we are very optimistic and encouraged by what we're seeing in eteplirsen and the exon skipping therapies, many of which we've talked about here tonight. We have been engaged with industry, and with eteplirsen, the Sarepta trial, we actually met with Sarepta here this week. And we are doing everything we can to make sure that these trials move forward as quickly as they can. But to that end, we've also talked here tonight that we need to make sure that people are enrolling in the trials as they're coming about, and there are a lot of trials now that are available, and that people are finding out what trials they're eligible for by getting identified, so finding out what your diagnosis is and going to your clinic and making sure that you're in the registries that are available. There are a number of registries, so that as these trials are opening up, one of the things that slows these processes down is that it takes a long time to enroll in these. So we have so the Sarepta trial is open right now. There's an Adelerin trial that's open right now. There are a lot of trials open right now in these spaces that we need to make sure that we're moving them as quickly as we can so we can get these answers as quickly as we can. MDA is right now with some of our partners championing the MD Care Act to make sure that there is funding for the Wellstone centers and the research that needs to be done. And we need to make sure that gets reauthorized. So we've put out reminders to our whole community to make sure that we're reaching out to our members of Congress to make sure that this bill gets reauthorized. And there is also a White House petition, so just make sure that you know that has not come out of the White House. We are petitioning the White House. And the petition states that we support accelerated approval for safe and effective therapies for Duchenne muscular dystrophy and other therapies. So if you support that statement, we encourage you to sign that petition. You can do that electronically and go to our website and find out how. And we need 100,000 signatures by the end of the month for that to land on President Obama's desk. So there is some timeliness to that. But the MD Care Act and the White House petition are the two ways that we're working that this month.
Thank you. I think I got it.
There's another question. I am checking into fetal stem cell replacement for my 7-year-old son who has Duchenne's. Have you heard of any success stories? We would have to go to another country and pay $30,000 for the initial procedure and $12,500 for the follow-up examinations. So I'm going to tell you what I know, and I'm sure Dr. Day can add more in terms of Duchenne, but definitely in ALS and other diseases. Stem cells are extremely exciting and have great promise. And from what I know in Duchenne's, there have been studies in mouse models and in other models where stem cells engineered to express the dystrophin protein or injected straight into the muscle have shown some change in these models. And I believe there are some in human as well, in direct injection into the muscle with increased expression of the protein. So great promise. And the issue, though, for many of our patients, especially in the ALS community where this is also a concern and a desire, is that although there's great promise, it's not quite to the level of go to the infusion center and get your stem cell injection. There still has to be a process of studying the impact of these cells in patients, and there are many issues that have to be dealt with. Number one, stem cells have the potential, depending on the type of cell, to turn into many things. And so that has to be controlled and monitored, and we're still learning that. In addition, how long does it last? And how do you get it to the point, to the place in the body where it can have an effect? And when do you give it and how often? If you're using viruses, although that's not necessarily stem cells, but viruses carrying the protein, carrying the gene, what impact does that have on the person? And what type of stem cell are you using? Fetal stem cells or stem cells derived from other cells in a body and turning them into other cells? These are all questions that are being studied. We're getting a lot of information, but as I tell my patients, we're not quite ready to write the prescription. And so in response to this question, and also to what my patients ask me, often they're attracted to go outside the country because they hear these wonderful stories of cure, of people getting up and walking or getting off the ventilator machine. And not to dash hopes, but just to give our patients realistic expectation, is that if there was something that miraculous, you wouldn't have to go out of the country for it. And that the scientific rigor needed, Dr. Day spoke about that, needed to prove that it truly does benefit you, is really to protect the patient and to make sure that we as clinical scientists honor the process of the scientific investigation and evaluating each other's work. It protects the patient. Because just as something can be beneficial, something can be horribly harmful to you as well. And so I always caution our patients, if you have to leave the country, if you have to spend this amount of money with this promise of cure or major impact, you need to be very worried and suspicious. If you're emptying out your bank account for this, then there are concerns because it has to go through. And I'm not saying every place outside of the country. There are stem cell research that's notable and performed by experts outside of the United States, but talk to your physician, talk to your care provider about what you're looking into. And most research, at least at this level, is covered by some sponsors. So if you're paying out of pocket significantly for this treatment and it hasn't been proven, then I'd be very, very suspicious and hesitant. Dr. Day?
No, I think you said it beautifully. I think, stem cells have a lot of promise. There's a lot of hype around them, and I think it's very important to be cautious. The neuromuscular research community is incredibly broad. I mean, so that we work with people all around the world. I mean, we're this little tiny kind of community, actually. It's just that we're spread out over the entire world. And so we get together, at various meetings, but we're pretty aware of what's going on in the more rigorous centers in most countries. And so I think there are very few legitimate treatments out there that haven't kind of come up through that system. And that's certainly true throughout Latin America, since I think this was Mexico that was alluded to.
You didn't mention the country.
Okay, maybe it's not clear. But the issue there is one of resources. And what I usually caution my patients is to not exhaust your resources for doing this. Now, we all understand the sense of urgency of coming up with something that's going to make a difference. We fully understand that. And, I certainly have had patients that have gone looking for novel treatments. And I don't, tell them that they can't come back to see me if they've gone off and done something like this. I very much want to stay involved, but my recommendation is usually that you not exhaust your resources in doing it. I mean, I have some patients who have all the money in the world, and so, $30,000 is not out of the question for them. But it's more than just money. I mean, it's time, it's energy. You're putting a lot into these things, and I would be cautious about approaching it.
Just to add, I talk to my patients, and I give them, 3 things to consider. How will it impact you psychologically? How will it impact you physically? And how will it impact you in terms of your resources and financially? And can you weigh the potential benefit of it versus the loss? The other issue is sometimes patients go and they go to places and receive treatment and there is absolutely no follow-up. Dangerous, dangerous, dangerous. And we have no idea the source of these stem cells, if they are stem cells. And so I just think go into these things with a lot of caution, and if you have a good relationship with your physician, then they should welcome the discussion.
We've had a lot of questions come in that are disease specific or very specific to individuals in their particular situation. So we just want to make an announcement that for people that have written in, we'll write back to them, but also we encourage everyone to go to see their local MDA clinic. If you don't know where your local clinic is, if you go to mda.org, there's a green box on the front page of mda.org on the right-hand side. Type in your zip code, it'll pull up all the clinics that are closest to you.
We have another?
Is there any comparison in Duchenne for kids that do steroids versus that don't do steroids? I mean, has that been looked at?
Is there a comparison between at what
Duchenne
level?
that do steroids and that don't do steroids?
Yes, absolutely. And on the average is that boys that use steroids walk 2 to 3 years longer. That 2 to 3 years. So this is starting, but while they're ambulatory. So that and that extra 2 to 3 years is during a significant growth spurt. So it's oftentimes being able to walk until you're 13 or 14 as opposed to 10 or 11. And so that is a key piece, that even though the disease still progresses, it does not stop the progression, but to be able to remain upright and walking through that adolescent growth spurt, or at least part of it, means that the number of patients that actually need spine surgery goes way down in steroid-treated Duchenne patients as opposed to Duchenne patients who have not used steroids. Steroids are becoming standard of care, or are standard of care. And although there are a number of families that choose not to use them, but I think that we still try to educate those families about it. And I understand the concerns. I mean, the concern is the different side effects that come on from steroids, and we listed some of them before, but they can also affect mood, affect behavior, affect sleep patterns, as well as weight gain and bone resorption and other things. So that I understand the concerns, but what we try to do is to get to see if the boys can start taking them, and then we'll see if we can avoid those issues or come up with a way of circumventing them if they do occur.
We looked at steroids with my son, but he was younger.
Yeah.
Now that he's 29, would it be beneficial at 29?
Yeah, we kind of touched on that earlier, and that there's very limited data on. Okay. And so I think that has to be taken on an individual by individual basis, so that there's still muscle function that could be preserved, both in terms of heart function, breathing function, and some upper extremity function oftentimes. And so that's what you're looking at. But then you get into the other questions about those side effects and whether or not is it going to be a net plus or a net minus, and that comes down to the individual.
Is there a level of heart and lung function that you just say, we're at this point, steroids aren't going to do much, or do you do it?
No. There's no one specific issue like that we can give. It really has to be tailored, but I think that the enthusiasm for the use of the steroids certainly would diminish if there was not much hope that it was going to do much good, because you are looking at the obvious side effects.
When he was diagnosed, it just wasn't, everybody wasn't doing it at that point. So I know they're doing more now.
Yeah,
so.
No, you're absolutely right. And I put that more on our own field of neuromuscular neurologists that took it. There was a long period of time where there was a lot of debate in the field. And so, you know, that I certainly will own a lot of the indecision on our part for that. But I think the field has now moved so that at least for the younger children that we make that recommendation.
What great questions and wonderful information here tonight. So I appreciate your time. And on behalf of MDA and the families that we serve, thank you very much for being here this evening, your work on the conference, and just the work that you do every day to make progress in the fight against muscle disease. We appreciate you very much. I'd also like to thank everyone in the room here tonight and those of you watching online. Please visit mda.org. We heard several times tonight that it's just packed with information on muscle disease, on MDA, on this conference, and on ways for you to be involved. So please visit mda.org. Also, the video of tonight's presentation will also be posted very soon. So thank you all very much for your time tonight. Thank you.